For sticking around for this super important topic. We're talking about lowering your risk for cardiovascular disease during American Heart Month. We're back with Joe and Kurt of UPHS Marquette. Now we want to talk about women's heart health specifically and the different ways that heart disease can present itself in women versus men. Joe, turning to you first, how might it present itself differently in women? Might they experience different signs or symptoms?
Yeah. So it's not all the time. I mean, there's generalizations where you have chest pain, feels like somebody's sitting on your chest. All right. So that's kind of the most general signs and symptoms that typically occur. But for females, for some odd reason, whether it be hormonal or whether it be whatever, it can kind of come in as more of an abdominal pain, or maybe a back pain that kind of runs up and goes into your jaw. We always tell, when we're doing classes, where I say, you know, if you have jaw pain, you have left arm numbness or pain, and then you have chest pain, you know, seek help.
Yeah.
Well, for females, sometimes it's the right arm, sometimes it's both arms. You know, so you have to be aware of that. So the presentation is not always what you see on TV. You know, and everybody in healthcare gets frustrated watching like Grey's Anatomy and all these.
They clutch their heart and fall to the ground.
And then it's like that represents like less than 5% of what actually happens. You know, typically people could be just sitting here, get pale, diaphoretic, and just go, I don't feel good.
Yeah.
You know, it might be something as simple as that. But for women, again, abdominal pain, we've had people come in the ED and go, oh, my belly is just, I think it's, you know, diverticulitis or something acting up, and they find out, you're like, if you had any chest pain, well, I might have had some chest pains. Throw them on a monitor, next thing you know, they're having an MI and they're sitting there talking to you right in front of it. So,
it can vary, and there is no cookie cutter list of this is exactly what I'm going to feel and how I'm going to feel it. And then you add in, we were talking during the break, and I've shared with you guys all at home that my dad died of a heart attack at 59, and then that really raised my awareness of my family history and things that I needed to be maybe pay a little more attention to. But then I turned 40. Right, and then I turned 42, and things change. Your body changes, especially for a woman at that age. And I'm going to say that it gets even harder to try to identify some of those factors because your body is doing all kinds of things that it didn't do in your 20s and 30s.
Right.
And for me, because of my, you know, the past with losing my dad, I always am like associating it to, could it be heart disease? Is this a heart condition? So, I guess my point is it's tricky, and especially, and age does play a bit of a factor in that.
Oh, yeah.
Yeah.
Yeah, I mean, like I was saying before, is that age 40 and age 60, there's been a lot of research on focusing on those two ages. At those 2 points, whether you're male, female, whatever, that's when your body starts to change. I mean, not only physically, mentally, whatever, and it's one of those things where you have to be aware of, all right?
Yeah.
So I'm not where I was before, all right? I just had my 59th birthday last week, and I'm like, all right, I'm getting closer to that 60 mark, and I'm like,
what's gonna happen?
All right, what's gonna happen now? I'm like, are things gonna get different? You know, all of a sudden I'm gonna be diabetic, or you know, who never know? Nobody ever knows. But it's very difficult, and Kurt runs into it from the EMT standpoint. You walk into a scene, and you can kind of elaborate on that. What's wrong? I don't feel good.
Right. So how do you determine?
Well, so we'll start by doing just a total assessment on the patient, getting some history, vital signs, a physical assessment, and then most of our patients end up on a 12 lead. We get them on an EKG on our monitor. We're able to look at that 12 lead. The paramedics know how to read the 12 lead, be able to determine if the patient is having what's called ST elevation, ST segment elevation, which indicates a heart attack. We're able to transmit that information to the emergency department, and we have a standard protocol that we follow as far as treatment, so we can start an IV, give them some medicine pre-hospital. We alert the hospital that we have a STEMI patient coming in, and most of the time with those patients coming in after we've transmitted, we go directly from the field up to the cath lab.
You say this is the leading cause of death for women. I'm curious why there might be a difference in men and in women. Does it have anything to do with the signs and symptoms being different, or maybe women are less likely to report those signs and symptoms when they have them?
They're underreported. They're under-recognized for the signs and symptoms. But then the biggest thing for me when I look at this is that they're under-researched. All right,
Yeah.
so they don't represent, when you look at clinical studies and you look at research, it's 60-40 split, 70-30 split between male and female. All right, well, when you're only having 30% of your trial people, are you really getting, you know, the full-blown effect of what's going on? All right, so having that underutilization of research when you have more like 80% women and 20% men, you know, I think you have a better opportunity there to recognize hormonal changes, recognize different gender changes, you know, and we just don't do that right now. You know, it's very male-dominated research. So
it is. It's getting better, but there is definitely a lot of
Yeah.
work and improvement to be made. So, as a woman, and perhaps a woman with history, in, you know, in their family, what can we do? What should we be doing? How can we take control? Skip the studies. Skip what hasn't been done. I want to do something for myself today.
Right. Yeah. So that's the thing is that you have to understand your risk factors, specific. So family history, big contributor to everything.
Yeah.
So once you have a family history of heart disease, you really have to like knuckle down and say, okay, all right, I got to watch these other things. Big thing, baseline things like blood pressure. Do you guys know what your blood pressure is?
I know it's good. I don't know the numbers. They always say
When's
it's
the last
good.
time you had it? And that's one of the things. So one of the biggest risk factors that leads to heart attacks is high blood pressure.
Okay.
And if we could be sitting here right now and both of us could be having high blood pressure, you're not going to know.
Yeah.
You know, it's one of those things where it's just there and it's causing a lot of damage over a long time.
Okay.
All right, so you have to be aware of that. You have to know what your blood sugar is, because once you get into that diabetic or pre-diabetes condition, then basically that's going to start deteriorating how your heart functions.
Blood pressure,
you know,
yeah,
and
yeah.
everything else. So
Yeah.
and how your body functions.
Yeah.
So those kind of things really need to be watched.
Cholesterol, that's another one? Okay.
Cholesterol's a big
Yep,
thing.
yep.
It's a big thing. So
So, I always say the more risk factors you have, the worse off you are, the less risk factors. And some of those risk factors you can control,
Yeah.
and some of them you can't. So if you're predisposed and you have a lot of the risk factors that you can't control, you better take care of the ones that you can control.
Sure.
Right.
Well, this is a really great place to take a break because when we come back, we're going to be talking about those risk factors and how to lower them. So stick around.